All right, well, I think without further ado, since we had a little bit of a prolonged set of introductions here, go ahead and get us started with our didactic for today. Chris DeCou introduced himself, and I just wanted to kind of preface his didactic this afternoon, just kind of really emphasizing, I think, that Chris is pretty much working with the people, the experts, both nationally and internationally, who are doing this work around suicide prevention, assessment, prevention, treatment. And so that's really kind of where his work is sort of grounded. And so I think I'll turn it over to you, and anything else you want to say about that, Chris?
Thank you. So I, again, work here at Harborview. I spend most of my time doing research. A lot of that's with Kate Comtois, who's really been enmeshed in the world of suicide prevention for a while doing this kind of work. But then I also see patients, medical inpatients, once a week on our consult service. And then I see a couple outpatients during CAMS, which you may have heard of, which is the Collaborative Assessment and Management of Suicidality. And that's working with folks really centered on how do we help people not kill themselves in the future, and making that the explicit focus of therapy for as long as it's front and center for them. And so I've had a lot of experiences related to community mental health. Before I became a psychologist, I was a firefighter, EMT, and police officer, so I saw a lot of how this plays out kind of out in the world, and all the ways that mental health kind of shows up before you end up in a hospital or end up in a clinic. And so that informs a lot of how I think about this now as a psychologist, both in my research and my clinical work. So we'll talk a little bit about facts and figures, kind of the impact of suicide. Most of you will have experienced this to some extent in your clinical work, but then my guess, even if this was just a group of folks we had pulled off the street, is that about half of you would have had someone close to you die by suicide. And if we were to think about how many folks in this group are likely to have known someone who's seriously attempted suicide, it would be a large number. And so I'll give some epidemiology kinds of estimates, but want to be really sensitive to the fact that this means a lot to all of us at some level, and that the likely guess is that many of us in this group have been pretty deeply and personally affected by this issue to some extent. We'll talk a little bit about risk factors, because we have to assess those when we do this kind of work, and I want to give you maybe a little bit different way to think about how to integrate and synthesize some of those risk factors, and then just a little bit of an overview of what you can do once you know that someone is suicidal and how it is that they're suicidal to kind of help them reduce their risk. So this is Diego de Leo's definition of suicide, and you'll have all these slides so you can read all the words later. But I just want to center in that last part, that suicide, in addition to being something you do on purpose to kill yourself, it's done for the purpose of bringing about wanted changes. And I want us to carry that as kind of a frame as we're spending some time together this afternoon, that people don't kill themselves for no reasons, people don't hurt themselves on purpose for no reason, that even if it's a mistaken or confused or somehow kind of less than rational kind of reasoning, people do these things for a reason, for a purpose, for some kind of function. And if you understand that, you kind of unlock the door to being able to help someone avoid that kind of outcome. These are terms that you can review later. The big one I'll highlight there that comes up a lot is that we want to kind of think about people as having died by suicide, and sort of avoid the language that we all kind of use, because it's often used where we might talk about someone having a successful suicide, right? Because that we would never think of as a success. And then sometimes there'll be the language of committing suicide, which sort of has that criminal connotation. So died by suicide is sort of what people are using currently. Also, people will say you completed suicide, or that someone has suicided. So in the time we'll visit together this afternoon, many people in the world will have died by suicide on average. About once every 40 seconds in the world, something like 800,000, 850,000 people a year die by suicide worldwide. And I put up this map just to show that even if you started to imagine the different geographic, climatological, cultural regions of the world, that there's quite a bit of diversity in this outcome across different nations. And so there are patterns that tie into many different domains of human experience, and even things like geography. but that it's also important to be fairly focused on sort of the national context that you're thinking about for suicidal behavior and death by suicide. And so for that reason, I'm going to kind of zoom in on the United States where we're doing our work. And so about 46,000 people a year die by suicide. The one thing to really point out that's caught a lot of folks' attention is that suicide is now the second leading cause of death among young people. And that's not just young people 19 to 24-year-olds. We could define that like 5 different ways and it would still be true. You could say 10 to 25-year-olds. You could say the 14 to 19-year-olds. Any way that you kind of define this sort of late adolescent, young adult, even middle adolescent age frame, you would see that this is true. And this is very compelling because that's been a new thing that's been observed. Thinking kind of beyond people who die by suicide, which is a relatively rare thing that happens, although far more often than we'd like. There's more than 1 million people who would say they've attempted suicide when you ask them. There's no good numbers for suicide attempt because no one's really keeping track. This is when they ask people, did you attempt suicide in the last year? More than 1 million on average will say yes. And then quite a few more who have seriously thought about killing themselves. Something that is extremely specific to the United States, this is a kind of a US phenomenon, is that it would be fair to say that about half the deaths that occur, half the suicide deaths are firearm deaths. And if we're thinking Washington State, you could say most suicide deaths are firearm deaths, and you could say most firearm deaths are suicides. And that is a really particular kind of thing in the US and something worth thinking about in terms of not just why that might be the case, which could be interesting to think about, but really to think about how does this inform, how does this guide what we would do to help someone not to die by suicide, not to seriously hurt themselves as part of a suicide attempt. So similar to that big pattern I showed you for the world, there's meaningful variation in the United States when we look at suicide rates. I can see it on your faces. You've already seen the pattern, which is that you can tell that kind of more rural, more remote places tend to have these kind of deeper shades of orange, tend to have higher rates of suicide. And that's meaningful even within Washington State because we have a pretty big range of urban kind of and rural communities, where the more rural your community is, the more likely you are to see an increased rate of death by suicide. And that is also challenging, right? Because often resources are more limited in a rural area. And so you're always kind of working with this tension in how we address risk in places where resources are limited. You probably saw the CDC report that came out. It was all over the news several weeks ago, but suicide rates continue to kind of inch up in the United States. And as has been true since they've been keeping data, men die at a higher rate of suicide than women. But you probably have also heard there's kind of a gender paradox here where women tend to attempt at a higher rate than men, with a few meaningful exceptions. So if you look at like prisons, some military contexts, they're a little bit more even. But in general, there's this paradox in suicidal behavior. Looking at Washington, you see a similar trend. So there was some, you could even think about a little bit of a drop, but really since about 2000, there's been a steady increase in the rates of suicide. Certainly not a spike, certainly not like a doubling or a tripling, but inching upwards despite the tremendous efforts that have been made to reduce death by suicide. So there's a mountain of theoretical and academic writing about why people die by suicide, how people die by suicide. I've tried to distill how I think about that into these 4 points, because I think they're the things that I assume about suicide that really guide how I work with patients who are kind of struggling with suicidality, who have disclosed suicidality. And I think these are the assumptions that enable us as providers to really give it our all and really think effectively about these behaviors to try and get in the way of future behaviors. So the first one, which might be novel, I don't know if folks have thought about it this way, but suicide is complex and fearsome. To engage in a suicidal behavior, a lethal self-harming behavior, you have to be able to stare down death in a way that most of us do not have the capacity to do. And that's a real important point, because if you think of it this way, that it is complex, that it takes the ability to really look death in the eye, it kind of leads into that next point, that you can't just be that person who can engage in this very fearsome behavior unless you've had experiences over a long period of time Experiences of physical and psychological pain and provocation is how you might say it. Basically, being able to acquire that capacity takes a lot of time. You could probably think of people in our communities and our society who we really count on to be fearless about death, where it's part of their job. So we are all absolutely thrilled that police officers, firefighters, EMTs, other first responders have fearlessness about death. They are able to manage that fear that makes all of us run out of the building so they can come in and be helpful. You could imagine folks who are in the military, particularly folks who are in kind of a combat role, have to have a certain fearlessness about death. You could think about physicians, particularly emergency department physicians or trauma surgeons as two examples, where they would have to be pretty comfortable being around death, dying, blood, guts, all this kind of stuff. Does anyone have a sense of what all those groups I've been listing have in common? One of the things they have in common? I'm sure there are others. Shout it out if you think about it.
They're all muted.
Oh, they're all muted. Uh-oh. All right. So one thing you might think about, one thing that they all kind of have in common is an elevated rate of death by suicide. It's something that you could look at that's kind of surprising to think about until you think about this core assumption that folks in these professions, folks in these roles get a lot of exposure to death and dying, pain and provocation, and to many ways have been found to acquire a fearlessness about death that's fairly unique. Third point here is that it's not just that people who die by suicide really want to be dead. It is that they have this capacity to do so. And with desire for death, I just want to point out that it's not just someone wants to be dead. Almost always there's also a desire to be alive. And it's this ambivalent process, kind of a push-pull. Last point here, and it's going to really lead into how we think about assessment and intervention. Just for a minute, think with me about house fires. Think with me about how we prevent fires in homes and buildings in our culture. We don't just park fire trucks in front of the houses we suspect are going to be the ones to burn down, right? That would be kind of silly. That probably wouldn't work very well. It wouldn't prevent a lot of house fires. What do? We have smoke detectors, laws and regulations around consumer products to prevent things that might catch on fire, building codes, and we have fire stations, EMS agencies with very expensive equipment and very highly trained personnel in pretty much every community. Comprehensive approach. If you were to think about then how we might tie that into suicide prevention, it is immensely difficult and not yet known how to predict any individual's ultimate risk of death by suicide, to predict the future. But what we can all do, the thing that we can really give it our all on, is be able to give everyone the best possible care and have a range of things that we do to prevent this outcome. So it's not about predicting the future or knowing what really can't be known for any individual. It's about doing a good assessment so that you give people things that will reduce everyone's risk, even if we can't tell what will happen ultimately. Okay, excellent.
I know you've got a lot of coverage.
So here's the list of risk factors that many of you know. You probably have a list of 13 to 21 or so things in your minds when you think about what you're going to assess. You have to know all of these things. That's true. But the one question to ask yourself, and you can look at these later in the slides, why is it that these risk factors predict a suicidal behavior, death by suicide, pick a suicide-specific outcome? And that why question is helpful in terms of when you think about what you're going to do, how you're going to intervene. And it also is helpful to imagine these things, again, in a process that unfolds over time and in a process that leads to kind of someone's ability to enact something fearsome and complex. These are warning signs. Evidence base for these is admittedly limited, but again, it's a helpful way to kind of think about things that might point towards a little bit more imminent risk. If I had to pick one on here that I think really is one to pay attention to, it's some version of feeling trapped. And if you see that sense of agitation, pressure, I've just got to do something, I feel stuck, I've just got to do something, do anything, I think that's one of those signs, if you had to pick one, that really is worth keying on. So that's where I think people start to enter that state of being able to enact lethal self-harm. So you're going to assess these things. You have to know the answers to all of those things, understand someone's ability to enact a lethal self-harm behavior. Recent standards of care that came out that are really important are these 4 basic things. Is kind of what it boils down to. So one is, does your system have a way to identify people to make sure everyone is being screened at some level in some way, explicitly being asked, have you had thoughts of wanting to hurt or kill yourself? There's got to be some kind of risk stratification. I'll give you a couple tools for that, but I'm just going to put one note in here that there's not a strong evidence base for this predicting outcomes. It's more about helping you think about what interventions have to be brought to bear on what time frame. Again, best possible care, not predicting the future. The one thing to really get in there is a safety plan. I'll show you an example. And then absolutely critical, and the thing that many of you are engaged in, is getting people tied into some kind of regular outpatient care. So here's some goals that you can look at and be thinking about, just to jump right into how you assess some of these things. I put some model questions in. So again, you have to understand someone's desire for death. Do they want to die by suicide? Do they want to die? But then it's also, and there's some domains of that you can have these example questions to help you with. But then it's also this piece. To what extent have you acquired the capability to do this behavior that is very difficult and that most of us would even struggle to think about doing because it is so fearsome? And so these are all the things. Big one here is access to lethal means. We just did a survey of emergency departments in Washington. This only gets assessed about 40% of the time. Huge area for all of us to be thoughtful about, and really seeing if people have access to guns, medications, other dangerous objects, and specifically anything they've mentioned. So you can't assess every dangerous thing in the whole world. That's not possible. You can't insulate someone from every dangerous thing in the whole world. But if your patient tells you, yeah, I've been thinking of killing myself with my CPAP machine, you're going to focus on that, right? Even though you wouldn't ask every patient about if they use a CPAP machine or thought about using one to hurt themselves. But you are going to ask every patient ideally about guns, large stores of medications, and then if ligatures, things they can use to hang themselves, are something that's relevant to them. Painful and provocative events, certainly occupation-related stuff, but also interpersonal violence, any kind of childhood abuse, physical abuse or neglect, any kind of victimization is really going to play into this, where we see higher rates of suicide among trauma survivors. And then again, putting it in patterns over time, and especially relevant for the case we'll discuss in just a minute, using something like chain analysis, which is really explicated in DBT, to get to the molecules of behavior, the smallest little points of decision-making and experience that one by one point towards a suicidal crisis and a suicidal behavior. And we can talk about that more for this, this case that will be raised. This is just a little decision tree. The punchline here is if someone has attempted suicide before and anything else is going on from your assessment, they're at least in that moderate risk category. They need a detailed safety plan and some kind of follow-up plan. If I had to pick one way to do a very brief assessment, I would get someone to tell me the story of what happened, tell me the story of your suicide attempt, tell me the story of how you got to the hospital or how you got to our clinic. And what you'll find, that feels very open-ended and like it would take a lot more time, and it can. But I think if I were to think about the most efficient way to hit all of these things without a very long structured assessment, this is what I would choose. And we have some wonderful practice-based evidence here at Harborview of being able to get to all these things you need to know by getting someone to tell you the story of what happened. And always chart review, collateral information. If you can get friends and family in there, you got to do that. That is huge, and that helps with all the stuff you need to do to keep someone safe. Here's more questions you can ask that you'll have in the slides. The top 3 things are all free. You can Google them and download them, and I'll also forward the PDFs to you. The bottom 2 things are wonderful gold-plated interventions for suicide, including chronic and severe suicidality. Pretty high burdens of training, consultation, and supervision to implement these. It may not be possible everywhere, so I want to give you both things with an emphasis on free tools like the 3 that are up above. Columbia scale looks like this. There's like 37 different versions. They all boil down to some really wonderful, tangible risk stratification things like this. With yellow, orange, red. Red, you have to do something right now, they can't leave. Orange, you need to make a pretty serious plan about follow-up. Yellow, there might be a concern, but you can be okay with a safety plan and a crisis line number. Safety planning, again, you can read all this later because I want to get into our case. It's not a no suicide contract. It's not a promise that someone may or may not be able to keep. It's a specific series of things so people can recognize risk, respond with their own strategies, talk to other people to get social support, talk to very trusted people who they can talk to about suicide, and then reach out for help with a crisis intervention option like the Crisis Lifeline or 911 if needed. Again, I just kind of put these here in order because you always want to orient people towards things ahead of going to the emergency department, ahead of getting into inpatient psychiatry, help people stay in connection with their lives. This will be very relevant to the case we're going to discuss. Getting people to give up dangerous things is huge because all the reasons people try and kill themselves are complex, overlapping, long-standing, durable patterns of human misery that can be like this big black cloud that takes time to understand, intervene on, mitigate, work on. But if you insulate someone from dangerous things, you occasion all the time you need to deal with this. Insulating someone from dangerous things, getting dangerous things away from someone is something you can do immediately. That gives you the space to do all the hard work that takes time, and sometimes a long time, to help someone not feel like killing themselves anymore. Okay, so really tangible point here. If you can, document in your notes VIP. Not everyone needs these things. It's saying that you had a discussion where you talked about the possibility of voluntary inpatient care, the possibility of increased visits, whatever that means in your system, if there's any way you can increase contact with therapeutic resources, and then the possibility of phone consultation, which if you don't do cell phone consultation, which is not possible in many clinics and many systems, you can always give everyone the suicide prevention lifeline. So documenting that you had this conversation is very helpful in terms of managing liability, but also orienting your patients to what is really available and that there's a lot more than maybe they thought of. I'll just leave these as interesting notes to read, and then also just some ideas for when someone is saying they're suicidal to get something that they want or need. It's very difficult, and that the big thing here is really outlining what it is they're trying to get. So we run into it a lot with people want to be in the hospital, so they're not out on the streets. So that's why they say they're suicidal. But you could imagine lots of ways that people might say, I'm suicidal, when they don't actually have an intent to die. And that's something where documentation and being very precise is very important. I'll leave these here as good notes so we can get into the case. 2 other tools to mention. These are publicly funded, so they're free. You can download them with anyone who has a smartphone, which again isn't everyone, but it's a lot of people anymore. On the left side of the slide, it's taking that safety plan and like making it more salient so people can reach out to people by pushing on their face. On the other one is the hope box, and you can actually load in pictures that inspire hope. So pictures of children, pets, family that go up in that middle part. For remind me, they would pop up there. You're gonna need to help someone do this, especially someone who's in distress. It's gonna take you a session, but once you've got it set up, it's incredible. Distraction or fun little games, relax me is exactly what it sounds like, and the inspire me are just really cheesy but kind of amazing quotes that I look at sometimes if I'm feeling kind of bad. So this is a good tool, and anyone with a smartphone can access these things, Android and Mac OS. And we ran through that real quick. So email me if you have any questions, anything you want to know more about, email me. We can talk on the phone. I'm available to you.
Thank you, Chris. That was terrific.
I'll say.